As a matter of fact, we have much more options nowadays than we used to have some time ago. Therefore, the diagnosis and prognostic stratification of lower risk MDS patients must be as sophisticated as possible. That means that the evaluation of somatic mutation has to be taken into account and programmed every time we need, especially we need to establish a sequential therapy. So the algorithm of treatment for lower risk MDS, it's very broad and it's very articulated, because we have, of course, anemia and symptomatic anemia as the first and most frequent problem for lower risk MDS patients. Beyond ESAs that have been used for decades and are still the first line treatment for patients who have the criteria of response, that is lower endogenous, low endogenous EPO level, better if lower than 200 units liter, not transfusion dependent, and lower risk, of course, without blast in the bone marrow. These are the patients that should be receiving EPO or biosimilar at the dose of 40,000 to 80,000 units a week. Now, ESAs have been approved finally in Europe for treatment of anemia, symptomatic anemia of MDS. And we know also that although the great majority of selected patients do respond, they will lose response after a while. And this is where it opens up the importance of evaluating the patients in the best way possible. We know, and we do treat patients with lenalidomide if they do have del(5q), and the response to del(5q) MDS patients to lenalidomide is limited by the presence of TP53 mutation. We learned in the last few months that multi-hit, multi-allelic TP53 mutations are the ones that are responsible for loss of response or lack of response to lenalidomide and responsible for progression to AML. So this is what we should look for when we need to move from ESAs, or we already have an MDS del(5q) patient who receives transfusion. We have to check for TP53 mutation, and in case the patient has only a monoallelic TP53 mutation, we may still, in my opinion, apply lenalidomide as treatment. Otherwise, we have to move to other treatment. And we should always take into account the possibility to treat patients with, in the end, transplant, even if for lower risk is less recommended than in an early phase. In last summer, in fact, another drug has been approved for anemia of transfusion-dependent patients with lower risk MDS. This is Luspatercept. Is a sub-Q agent, drug that has been approved for treatment of patients with ring sideroblast. That is, more than 15% of ring sideroblast in the marrow, or the presence of SF3B1 mutation and more than 5% as ring sideroblast. So again, we have another important weapon or tool, if you wish, in the cure and treatment of anemia in lower risk MDS. Of course, there are more patients, even if ring sideroblast ones are MDS-RS is very frequent. There are more patients who do not have these characteristics and still lose response to ESAs or never achieve a response, and should be treated with experimental drugs. Experimental drugs are the only option that is alternative to transfusions. And there are interesting ones like Emetastat, that is a telomerase inhibitor now under evaluation in a phase 3. And in the phase 2 has shown response in more than 45% of patients who were refractory to ESAs. So very interesting. A little bit of myelosuppression, so we have to select patients who are not severely cytopenic for neutrophils and platelets. But it's a very, very interesting agent. Another interesting agent under evaluation is Roxadustat. Roxadustat is an inhibitor of the HIF alpha hydrolase. The epoxy-inducible factor hydrolase is Roxadustat is oral and is inducing a 38% of transfusion independence in patients who did not respond to ESAs and have a low transfusion burden. So very interesting and exciting moment for lower risk patients with anemia. But there are other cytopenias like thrombocytopenia that still need to find a drug, a specific drug to be approved for lower risk MDS patients. Eltrombopag and romiplastin have shown activity, lowering the hemorrhagic episodes and increasing the number of platelets in two phase 2 studies, but have not yet been approved. So the oral drug, eltrombopag, that is approved for aplastic anemia and ITP, and romiplastic sub-Q approved for ITP, are still experimental for lower risk MDS patients. There are other thrombomimetic drugs that are under study. And what is interesting is that if you have a patient with lower risk and more than one cytopenia, especially patients with anemia and thrombocytopenia, they should be treated with drugs like hypomethylating agents. Now, in Europe, they are not approved. In the States and in other countries are widely used as a second-line treatment. The interesting part of this is that the oral azacitidine, CC486, has shown activity in a study a phase 3 study that has been closed after several difficulties in enrollment, and has shown activity in increasing platelets and red blood cells, but has some toxicity, especially for neutropenic patients, but is indeed a very interesting drug. Whereas good results have been obtained by the MD Anderson group, treating lower risk MDS patients with 3 days of standard dose of azacitidine and decitabine. And therefore, I think that we will see more about oral drugs like also Astex that has not been yet, results have not been yet published for lower risk MDS patients. Of course, we are going towards what is called a total therapy, a total oral therapy. Patients are elderly. They do not like to come to the hospital too often. Lower risk patients have a very long expectancy of life and longer, we hope. So it is very important to improve further their quality of life by providing oral drugs. Finally, little is left, I would say, for neutropenic patients. These are at present the most difficult ones to treat because there is not a specific drug. Filgrastim G-CSF is, of course, very efficient, but it hasn't shown an advantage when used in prophylaxis. So it's good to be used in neutropenic fever and just to be employed in case of infections. As I mentioned, more experimental drugs are under evaluation. There is a lot of work because the patients with low risk MDS are the majority of MDS patients with a prolonged survival. The younger ones should be very carefully evaluated for inherited predisposition and possibly move to transplant not very early, but surely a program of transplant should be really designed carefully. For the patients who are a little bit older and cannot undergo a transplant, or the risk of transplant is higher than the risk of transformation of MDS, not only cytogenetic and marrow cellularity, but also the presence of somatic mutation must be evaluated, because this can help us also in experimental choice. For instance, IDH1 patients, mutated patients with low-risk MDS, could be enrolled in a study that has been promoted by the GFM, the French MDS group, and has become an European study. And we are waiting for the first patients and the first results in this interesting approach. So I think it's a very exciting moment for patients with low-risk MDS. And we still need, for instance, to understand the importance of immunosuppressive therapy, the selection of patients who could respond. I think there is a lot of work to be done, and a lot of options and evaluation of agents that are still not yet well known.